This is Chapter 28, Endocrine Dysfunction, Part 3. So, long-term complications for diabetes mellitus are type 1 kids. The long-term complications are very similar to type 2. They happen because of kind of chronic high blood sugar, so they develop slowly. That high blood sugar will do damage to the nephrons in the kidneys, and you get that, kidney damage. Nephropathy. It will do damage to your nerves, so you get neuropathy. Neuropathy can be either lack of feeling because you've interrupted the nerves being able to send up a stimuli, or it can be constant pain because the nerve is being stimulated, the pain nerve. So it happens that sheath around the nerve is what is damaged. And then all the blood vessels, small and large vessels, that high sugar in the blood basically becomes sticky. And so then we get proteins sticking and the sugar all sticking and narrowing down those vessels. In a small vessel, that will plug it. In a bigger vessel, we get sclerosis. So small vessels like the retinas of the eye, those small vessels in there can get plugged up and damaged, and then retinopathy. So vision becomes impaired as part of some of the long-term complications of diabetes. So when we're dealing with type 1, we must give insulin. There is no other choice, and insulin can only be given sub-Q. There is no other choice. So what we try and do, we might do twice daily, before breakfast and before dinner, mix a short acting with an intermediate acting, or give a rapid acting and an intermediate acting. If you remember, regular and NPH, your short and your intermediate, can be mixed together, but our rapid acting ones, Aspart, Lispro, those don't mix. So then you have to do 2 shots. So it just depends on what's ordered. But twice a day, once before breakfast, once before dinner, and one covers that meal right then. The other one peaks and covers the rest of the time. That's what we used to do. What we are doing more now with kids is multiple daily doses. And this is usually a pen where they twist the top and you see in a little window the number of units. So rather than drawing it up in an insulin syringe, it's shaped like a pen, and you just dial in the number, and they take multiple shots of that. So before every meal and before bed, they'll take a shot. When we get them stable on multiple daily shots of either regular or rapid acting, then we can switch them to a continuous pump. And that's really our goal with these kids, is the continuous pump. So it is set to give their basal need all the time. And then when they're going to eat, they plug in the extra that they need for that meal. And here's a kid who's doing shots, and these kids do their own, usually by 8-9 years old. So some of the monitoring we do, we're going to be doing that blood sugar monitoring before meals and before bed. Our book says the goal, it should be less than 126. I would say it's more likely the goal is going to be 80 to 120. In new onset, it's going to be higher than that because they want to bring them down slowly because they don't want hypoglycemic spells. They want to know how stable, how brittle this child is going to be before we get them down into those lower ranges. But once they're pretty stable, then probably 80 to 120. We're going to do hemoglobin A1Cs just like we do with the adults, because that gives us not just what's going on now, but what's been going on for the past 2-3 months, the length of the lifespan of those red blood cells. There is some interesting new technology out there They have developed cutaneous glucose monitors, so these don't require you to puncture the skin. They are able to look through the skin to see what the blood sugar is. So those they've been working on, but what I'm actually seeing being used are continuous glucose monitors. And these do go under the skin, but it's just a small little catheter, little needle that you push in, and it's continuously monitoring the blood sugar. So it's not just when you poke your finger. And it will alarm if it goes outside of the limit. So it catches maybe some of the highs or the lows before the child is feeling any symptoms or before they actually were going to check their blood sugar. So it hopefully catches those highs and those lows quicker. There are some that actually they're trying to get to interface with the continuous pumps. So as the blood sugar goes up, the pump automatically gives a little more. As it goes down, the pump gives a little less. At this point, I think they're having kids using that continuous glucose monitor. When it alarms, have them actually poke their finger and check and verify that the pump is right. So we're not quite trusting it, or verify that the monitor is right. So we're not quite trusting them to have an automatic feedback with the pumps yet. So urine testing for ketones, this isn't done very often. They might do it especially during illness because it does tell you that your glucose is on the high side, but it's not something that's done very often. And here's the picture of what I was talking about. This is the pump that we like to use. So this is a subcutaneous little catheter here, and depending on the child and what they're taught to do, 3 days, 5 days, something like that, they're going to leave it running continuously and take it out and change it. This is set for their basal need, and then they can increase or decrease it. Increase it and give themselves a dose before they eat, or if they're running low, decrease it. And here's that continuous sensor. So it's just constantly sensing and then alarms if they get outside of what their limits are set for. So nutrition with diabetics. They do need to have consistent intake of food, especially those kids who are doing the twice-a-day shots. They've got to eat at regular times because their insulin is going to peak, and they need to eat so that they don't get those lows. What we're doing now with most kids is carb counting. So they look at their meal, calculate how much carbohydrate they're going to have, and then they adjust their insulin based on that. So they're taking exactly the amount they need for the amount of carbs they're going to eat with that meal. And the nice thing with those pumps, right, it's set at their basal rate, and then they just punch in the extra, give it to themselves, and eat their meal. Their nutritional needs don't change, right? They need the same sort of good balanced nutrition that other kids need. They do need to be careful, though, because food, insulin, and exercise all have to be kept in balance. If they're going to do extra exercise, they need some extra food. And the nice thing with these pumps is we let kids be a little more normal. They can go to a birthday party and eat some cake and ice cream and just take extra insulin. So that's not something we want them doing every day, but they're no longer limited that you can't ever have anything that's got a whole lot of concentrated sweets. We let them be a bit more normal. Here's a kid doing his blood sugar, and here he's reading it off the glucometer. Most of these are very smart nowadays, and they keep track. We used to make the kids write it down and bring it into the doctor, but anymore this is all electronic. So exercise. Exercise is good for everyone. It's good for kids and it's good for diabetic kids, but they need to make sure they're balancing it with their blood sugar levels. that extra exercise is going to use up the sugar that's in the blood. So they've got to make sure that they're not going to drop low. So having extra snacks, hopefully they get to know what they can tolerate and how much extra they need, but extra snacks before an activity. And exercise often actually decreases their insulin requirements because everything just works more efficiently. So it's not that they make insulin, because they don't, but it makes it work more efficiently, and they can actually sometimes start using less, needing less. So hypoglycemia, this is bad, right? You will die quickly with a hypoglycemic spell. Most of the time this occurs before meals or when the insulin has a peak. So it's really important for them to know what insulin types they're using when it peaks. And the other time it will hypoglycemia can happen is during physical activities. If they go out, use up that sugar without taking any extra food. So the simpler a carbohydrate is, the more rapidly it's absorbed. So if they have a hypoglycemic spell, we want a rapid releasing sugar. Juice, candy, something that's pure sugar and is going to be absorbed and into the bloodstream quickly, but we don't want it to spike and crash again. So we want to follow it up with a complex carbohydrate and some protein. Protein to slow down the absorption so we get back to that nice steady rate. In severe hypoglycemia, glucagon is auto injection, so a parent can take it and just kind of bang it into the thigh and it auto injects. That would be for when a child is not conscious and can't swallow some juice or something. Hypoglycemia will kill you quickly. Hyper will kill you slowly. So if in doubt, treat for hypo. And if it turns out they were hyper, well, we have plenty of time to correct that. But in hypo, we don't have time. So we're going to treat them as hypo until we figure out otherwise. Illness. When a child is ill, they still need their insulin. They probably are going to need different dosing, but they still need insulin. Most of the time they're going to run high when they're sick, even if they're not eating, because just the stress, those stress hormones of being sick tend to make blood sugar go higher. That hyperglycemia, remember the extra sugar in the blood is going to pull in fluids and make cells and tissues dehydrated, so we've really got to encourage them to drink extra fluids when they're ill. And we're always worried about them developing diabetic ketoacidosis. So dehydration is one of the big parts of that. They become profoundly dehydrated. So fluids to overcome that dehydration. Their electrolytes get way out of balance because they're acidotic. All that hydrogen ion throws everything else out, especially the potassium, and the heart does not tolerate changes in potassium. So electrolytes have got to be replaced. And then usually in ketoacidosis, we're going to first give them fluids, get them hydrated, and then part of that fluid is electrolyte replacement. So we're probably using buffering, so like K-acetate rather than KCl. And then once we know where they're at, then we're going to start a low dose of regular insulin, probably on a continuous infusion pump, and have some glucose in the IV fluid so we can really adjust up and down on both at the same time. That's the ICU for diabetic ketoacidosis. That shouldn't be done anywhere else. Kids can start doing their own blood testing. The blood sugar by 4 to 5 years old. By 9 years old, they should be able to do their own insulin. We're going to want somebody to double check it when they're drawing it up, but they can do it themselves. And then some of the nursing diagnoses we might use. Risk for injury, knowledge deficit, lots they're going to have to learn.